Good day, everyone. I'm Dr. John Ward, the Director of the Coalition for Global Hepatitis Elimination at the Task Force for Global Health in Atlanta, Georgia. It's my pleasure to welcome you to the second edition of the webinar series presenting and discussing NIH research that's advancing our progress toward hepatitis elimination in the United States and globally. This is one of a series of webinars that began last month, where we outlined in general priorities for hepatitis research at NIH, and now through going through in more detail different types of research that's being led by NIH. Next slide, please. I want to thank our organizing committee. We have representatives from the Institute and offices of NIH, as well as from CDC, as you can see listed here. I want to thank my co-chair, Betsy Reed-Conley, for helping bring the organizing committee together and to identify topics for presentation in this webinar series. And I want to thank all the members in that regard as well. Next slide, please. So today we're going to be looking at collaborative research on hepatitis C detection and treatment among persons who inject drugs. This is a critical population that's in great need of prevention, testing, and treatment, and so, it's a critical area for us to eliminate hepatitis C in the United States. The agenda is outlined here. As we go through the agenda, please be mindful of the Q&A option below, as well as the chat option below. Please submit questions as the presenters present their work, so we can do our best to take those questions and bring them up for discussion. If we aren't able to reach all the questions here, everything about these webinars will be available at that website listed here on this slide, including the recording of this of the webinar, the PowerPoint presentations, a summary of the presentations, as well as answers to the questions that are put forward to the presenters. So we hope that will be a valuable resource for you going forward. And everybody that's registered will be alerted when that information is available at this website. At this stage, I'll turn it over to my colleague, Dr. Wilson Compton, who's the Deputy Director of the National Institute for Drug Abuse, who will be the moderator for today's webinar and will be taking us through our presentations and discussions. Wilson.
Thank you very much, Dr. Ward. It's really a pleasure to be here today. And on behalf of the organizing committee, to welcome you to our session on hepatitis C elimination among injection drug users, and to highlight for you just some of the work that the National Institute on Drug Abuse, in collaboration with multiple other groups, has been undertaking. Now, I will have an opportunity to introduce each of our speakers, but I am so pleased to be able to introduce you now to Dr. Nora Volkow, the Director of the National Institute on Drug Abuse, or NIDA. Dr. Volkow has been the Director of NIDA since 2003, and during this impressive tenure, she's been a tireless and an effective leader in using addiction science to drive improvements in the prevention and treatment of drug use and harms related to drug use. It is with Dr. Volkow's leadership and vision that we launched the studies that you will hear about today. And please join me in a virtual, rousing welcome for Dr. Nora Volkow.
Wilson, thanks a lot. And John, thanks a lot very much. And it's a pleasure to me to be with all of you here for many reasons, including how important this topic is. And as John basically said, we need to address the hepatitis C treatment on individuals with injection drug use, because otherwise we're not going to control the infection. And I have to give credit to John and CDC for being the first ones to actually recognize that there was an increase in hepatitis C that was driven by increase in injection very early in 2000. And he came to NIDA and brought it up, and it was clear. And we have not realized that injection drug use was going up, but he did. And this was what was driving the hepatitis C and continues to drive it. And the rates of injection drug use are very high. And that is in part linked and driven by the opioid crisis that we're currently living. And while there's an enormous amount of attention in general before COVID on the opioid overdoses, there has been almost no attention to the parallel increase in hepatitis C that's happening on those individuals, where the prevalence of infection is very high. And actually, though we do not know that what exactly it is clear that in many instances the infection is not recognized. Now, part of the lack of attention may be to the fact that we do have very good cures for hepatitis C, and therefore the urgency to come up with interventions is not the same as if it were that these individuals would have no alternatives. But it's actually more challenging than that. And I think that as we view the COVID pandemic, I mean, I hope that we do learn from lessons that have emerged. And one of them is the tremendous disparities that exist in the population. And we've recognized all along that health disparities are prevalent for almost every medical condition. And that's not any different for substance use disorder, nor is it different from hepatitis C. But if one looks at the numbers in terms of the disparities that relate to hepatitis C, as it relates both to having an injection drug use problem, which is actually highly, highly stigmatized, or being from a minority group, it becomes evidence that the outcomes are very, very different. Yes, we have incredibly effective interventions for curing hepatitis C, but those interventions are costly. And as a result of that, there is a limit actually of the willingness of insurances to pay for them. When you consider actually individuals with substance use disorders, many of whom may be uninsured or be insured on Medicaid, and the numbers speak for themselves, you can basically start to realize why we have not made major dents in curing individuals with substance use disorders that have hepatitis C. There is, on the one hand, a reluctance to be, again, because it's stigmatization, of putting the amount of resources needed to provide the treatment of these individuals unless they are very advanced on the disease. And as a result of that, they actually are jeopardizing their health. So we're here together on that one hand to say, yes, we recognize that the disparities are there and we need to address them. But the other thing that I think that the COVID, at least to me, has shown me very eloquently, and that is a positive thing, is that it is the interactions between organizations and people that come up with the solutions. And this meeting today epitomizes that. The presentations that you're going to be hearing today, 3 of them, very different, are nonetheless the result of very productive collaborations between institutes at the NIH, between agencies, CDC, SAMHSA, the Appalachian Regional Commission, as well as industry and the states. And it is these interactions that have made it possible to see some of the very promising outcomes that you're going to be hearing. And that will provide us with models that give us the opportunity to implement access to treatment to every individual that has hepatitis C, whether they have a substance use disorder or not, whether they inject drugs or not, or whether they are coming from an underrepresented group. The medication should be available and accessible to everyone. And the scientists today can show us that this is possible. So because of all of that, I'm so very excited to be part of this, joining you today on this webinar. And I look forward to hear the presentations. Thanks very much. And Wilson, I turn it back to you.
Thank you very much, Nora. Much appreciated. Well, let me turn now to our first presenter, Dr. Jennifer Havens is professor at the University of Kentucky College of Medicine and is an epidemiologist with an appointment in the University of Kentucky's Center on Drug and Alcohol Research. Dr. Havens' primary research interests include the epidemiology of the prescription opioid use issues in rural Appalachia, the comorbidity of substance and mental disorders, and HIV and other infections complicating drug use. In addition to serving as principal investigator on the large-scale NIDA NCI-funded hepatitis C treatment study in Perry County, Kentucky, which is the topic of her presentation today, Dr. Havens is also principal investigator in an ongoing NIDA-supported grant called The Effect of Structural Interventions on Substance Use and HIV/HCV Risk Among Rural People Who Use Drugs. Please join me in welcoming Dr. Havens, who will be presenting to us on the Kentucky Viral Hepatitis Treatment Study, or KEY-TREAT, KY Treats.
Thank you. Let's see if hopefully we can get this pulled up. Let's see, share. Can you all see that?
Yes.
Fantastic. That's a win already. So thank you all so much for hosting this webinar, and a particular thanks to Drs. Ward and Compton and Lindsay Hebert, who were instrumental in inviting and then making this so easy for me to be able to present this very exciting study to you all today, the Kentucky Viral Hepatitis Treatment Study, or KEY-TREAT. Oh, come on, now it doesn't want to move. Move. Okay, let's start over. There we go. So can you all still see that?
Yes.
Okay, excellent. So the overall goal of KEY-TREAT is to eliminate the transmission of the hepatitis C virus in Perry County, which is a small county in eastern Kentucky, by drastically reducing the community viral load. So in essence, a micro-elimination study. And this is our clinic. It's in Hazard, which is the county seat of Perry County, Kentucky, and it's within the Appalachian Regional Health Medical Mall. So we are a nurse-led model, and as you've heard already from several of the folks that have spoken, what we're looking to do is have a model program that can be implemented around the country or potentially around the world. And in this case, we're focused really on rural areas. So we wanted to make it such that some of the results from this study would potentially be able to be translated to other areas who are facing similar issues with hepatitis as a result of opioid use, continued opioid use and injection. So we're trying to have a very streamlined protocol, and going through our visit schedule, we have a baseline visit. It's day 0 to establish our eligibility. They have to be a Perry County resident, and that's because, as Dr. Compton mentioned, we did have a donation for our drug, so we have a limited supply of drug. Detectable viral RNA, and they have to be at least 18 years of age, and that again is due to the drug and the FDA approval. So we do point of care testing, anti-HCV, so antibody testing for HCV and HIV, and we are fortunate to have access to the GeneXpert, the Cepheid platform, to conduct viral RNA testing, which will give us RNA results within about 45 minutes. We do a medication reconciliation, and medication is initiated on day 0 for eligible participants. So those folks, anybody hearing that? Okay. And medication is initiated on day 0 for those participants who have viral RNA. So we'd like to have them come back at 2 weeks to see how everybody's doing. And we expect to see if they've been using the medication as directed. We expect to see declines in their RNA because the GeneXpert is a quantitative test. We should be able to see significant reductions in their viral RNA. So if they're not doing well at 2 weeks, we try to intervene wherever we can, talk it through with our social worker and say, what's going on? Is there anything we can do to help you to be more likely to use the medication? If there's something going on in their life we can potentially intervene on, we try to do that. If they are doing well, we will send them home with 6 to 8 weeks of medication, have them come back at 12 weeks. The nice thing is we have some flexibility there. So folks that aren't doing so well, we can see them every couple of weeks. And those who are, we can have them come back at 12 weeks and then come back for their SVR visit. And that's really what, in terms of a treatment protocol, that's where it could potentially end. Obviously, we'd want to see them clinically after that as well. But what we're doing from a research standpoint is hoping to expand the data in the literature on reinfection and seeing them at 6 months and 1 year post-treatment completion. So really we have them for about 18 months and we can really look at some of those long-term outcomes, which we don't have fantastic data yet. There have been some wonderful studies throughout the world, but the data often don't go beyond several months out. And so we're trying to rectify that and get as much post-treatment SVR data as we can. So as I mentioned, we were fortunate to receive a drug donation from Gilead. So Sofvel, 1 pill per day for 12 weeks. As you all probably know, very favorable side effect profile. Nausea and headache is most commonly reported. And that's another reason we'd like to bring folks back at 2 weeks. If they're having some issues with any side effects, we can potentially work with our nurse practitioner, will work with them to see if there's another time of day or if they could take it with a meal and work through any of those issues so that they are, again, motivated to continue with the medication. We do have daily text reminders, which are incentivized at $1 per day if they respond with a yes, a no, an emoji, have a nice day, whatever. If they respond to us, we know that they received the reminder and we will give them $1 a day. And that's worked really well thus far. And many of our participants also have this medication device, which is on the right. And it's the Take as Directed, or TAD, developed by Intent Solutions, really with the purpose of dispensing scheduled drugs. That box in the middle is actually a fingerprint scanner. And all the way to the right, it's almost like a gumball machine. It delivers the pill. And it's about since it's 1 pill per day, and we have set the time with each participant to which they'll take it. So we have about a 24-hour window for which it will open. And the interesting thing is we've been able to look at the daily text reminders, the responses to the text reminders, and then see when they actually take their pill. And we see that they're very highly correlated, which is wonderful. And then if we have folks who have reactivation or recurrent reinfections, we do have Vosevi, which is Sofvel Vox, at our disposal, but we have not used it as of yet. So just in terms of what we do for labs, obviously I mentioned we do rapid testing for antibodies, HCV, HIV, and we do have the rapid quantitative testing for HCV viral RNA at our disposal as well. Given that it's not FDA approved, Sofvel, for use in pregnant women, although we've seen a couple of fantastic results coming from some studies, we do urine pregnancy screening for all women of childbearing age. And we have removed one woman from active medication. She was pregnant at the 2-week visit, and she has since come back and restarted after she gave birth. And then we do a blood draw, and really the things that we're interested in from that are the HCV genotype in the fibrosis stage, which we're able to get from our LabCorp testing. And when we were talking through what this study was going to look like, especially, Drs. Ward and Compton, and we really were thinking about a sort of holistic approach to how we were going to be offering HCV treatment in a small community, making sure that the availability of treatment for opioid use disorder was there. And at one point in time, we thought we were going to provide it as well, but there's a lot involved with that. And that was perhaps going to even take more time to set up than the treatment program. So we've contracted actually now with 2 providers. And anyone who's interested in treatment, we will subsidize the treatment for them. We're doing hepatitis A and hepatitis B vaccinations. So we're kind of billing ourselves as kind of one-stop hepatitis shopping. We also are involved with the syringe program in Perry County, because if we're thinking in terms of how do we prevent reinfection, obviously if they're continuing to inject, then we would really encourage them to use the syringe program throughout their treatment and obviously post-treatment, especially if they achieve SVR. I mentioned our social worker, who has been really instrumental in establishing a referral network for all different services that are available in the community, which in some of these small communities, there is not a lot of availability. So she's had to get fairly creative in some instances. And then Kentucky is fantastic in that we're really kind of an all-in Medicaid state, Medicaid expansion, but we still have folks who are not enrolled. So she's helping them get enrolled in Medicaid as well. And then there's no Lyft, no Uber. Taxis aren't fantastic, but there is a medical transportation service that we've been able to contract with to go pick people up at their homes if necessary and bring them to us. Or if they need to go to the university to see our infectious disease physician that we contract with, then they can do so. We've only had, I think, 2 or 3 participants go up who had, they were cirrhotic. She really wanted to see them in person and establish that kind of long-term follow-up with them. But for the most part, we've been able to treat everybody in-house at our clinic in Hazard. So what are the primary outcomes? Medication initiation, and with that goes recruitment, screening, enrollments. How do we get folks to the point where they are enrolling in the study and they're actually initiating medication? How many people are we able to get through that 12 weeks of soft-val? Obviously SVR, so cures and reinfection are huge outcomes in this case. And we also are able to do a comparison to Pike County, which is our control county. And I believe our epidemiologist that is building that data set is on this call right now. So we will hopefully be able to start to look at the incidence, kind of the historic incidence and prevalence pre and post in both our intervention Perry County and our control county, which is Pike County. So what we're looking at here is the green bars are the people who have called, the number of people who have called by month. So we started in September of 2019. And I do want to note that basically we were in for 5.5 months and then COVID hit. So everywhere from March 20 on is COVID times. So we really had 5.5 months to hit the ground running. You can see in January and February of 20, we were going gangbusters, and then COVID hit. So I will talk a little bit about throughout the presentation about the impacts of COVID, but what we're seeing here is we've screened on the phone almost 500 folks. But only about 400 have come to do the in-person screening. So these are eligible folks in the green bars, and then those who actually showed up to do the in-person screening, which is obviously required to start the medication. We need to know if they have viral RNA. So we're losing about 20% from the call to the in-person visit, even if it's within 2 days. We try to get them in within 2 days of calling. So they could potentially go from calling us at 2 p.m. on Monday, Wednesday at 10 a.m. they could be on the medication, started the medication. So we know that there's a lot, that the motivation, especially in this population, waxes and wanes. And we try to get them when they're still in that mode where wanting to help themselves and really wanting to do something for their health. So we're looking at some of the factors and some of the little bit of data we have about them from the phone screening and trying to figure out who they are, why they're not coming in, and obviously attempting to intervene to get them in. So about half female who are calling, you'll see 38 years of age. And I'm sure Dr. Ward will attest to, even 5 years ago, the average age of someone being treated for hepatitis C was significantly, almost double that. So at least 60s, 70s. So we're really starting to see, this is the population we are hoping to reach. All but 4 folks that have called in had a history of substance use. About 40% are currently using, and about a little over half of those are injecting. And we've seen a huge shift from opioids to methamphetamine, which I know is happening in opioid using populations nationwide. This is not something that's unique. But what I think at the end of the day we'll have is data on whether you can get someone through 12 weeks of medication if they're actively injecting methamphetamine. And so far the answer is yes, you can. So this is looking at the total this is from the people who have called in and to enrollment. So 47% of the people who are calling in were actually able to enroll. And I already talked about the 20% that just aren't showing up to their intake appointment. The other 30% are either don't have antibodies or viral RNA for hepatitis C. So they're not eligible, obviously, for treatment. So basically half the people that call were able to get enrolled in this study. Those who are enrolled, slightly less than for females, and the median age goes up just a little bit, consistent with the population of Appalachian Kentucky, about 96.6% white. And we haven't had a whole lot of uptake on the offer for the subsidized treatment. And that's because almost half of the folks who enroll are actually already in a program, a medication for opioid use disorder treatment program, which is fantastic. And as I mentioned, Kentucky's Medicaid is very inclusive, and we've had a huge uptick in the number of people enrolled as a result of the Medicaid expansion in Kentucky. And it looks like it's working, you know, and being folks who look at treatment for substance use disorder, this is very encouraging. This was one of the hallmarks of Medicaid expansion is, can we get folks enrolled in substance use disorder treatment? So looking at the clinical characteristics, and I believe Dr. Ward mentioned this already. So if we were looking at the Medicaid requirements, and Dr. Volkoff mentioned this as well, it's people who were ill. So people who have F3, F4 fibrosis, that is not who we're seeing in this study. The vast majority have no liver damage thus far. So we would, if we had the Medicaid restrictions in place, which many of the states still do, you're not reaching this population, but this is a population that is potentially continuing to transmit the virus. So if we're thinking about eliminating hepatitis, these are the folks we need to be treating. So we are getting to this population, which I think is very encouraging. So in terms of medication initiation, 90% started on day 0. So if we had someone, oftentimes we'll have people who walk in who don't call, who just, they've heard from a friend about this program and they come in, they could potentially within 2 hours take their first dose. So walking in the front door and have their first dose within 2 hours. We do those medication reconciliations. So if there's potentially a medication interaction, we ask that they go to their primary care provider and change the medication, so primarily statins and PPIs, and we get a letter from the provider saying that that medication change was conducted. The other folks we don't start on day 1 are those who have a known hepatitis B infection. We also do hepatitis B testing as part of our lab work, so we can identify that as well if they're not aware of it. So we had one active HBV case who we offered to co-treat both their HBV and HCV, since we do have an infectious disease doc on with us from the university, and they declined. We also had our third patient that came in. We said, oh, everyone's going to be, you know, F0. Well, she was cirrhotic. So we had a challenging patient, our third person that walked in the door, and she declined treatment, and which was, I think, a little bit disheartening, but we've had a lot of success since. And then we have 5 folks who requested medication changes. We requested medication changes before we could start them, and they never came back. So in terms of getting folks through the 12 weeks of medication, about 3/4 have made it through all 12 weeks. Thinking about some of the things that we're looking at, obviously one of the things we're interested in, who are the people that don't make it through? So we've had 2 deaths prior to 12 weeks. Both of those, unfortunately, were overdoses. We've had 7 deaths total, all unrelated to the medication. We had, again, that one pregnancy I mentioned, and then 47 lost to follow-up. We had a homeless shelter that actually ultimately shut down. We had quite a few folks come in from there. They were very hard to keep track of, and we ultimately lost track of some of those folks. We have a great agreement with our local jail where we are, if they are incarcerated, we're able to bring the treatment up, and they are fantastic about administering the medication. In fact, our folks do really, really well that are incarcerated doing the treatment, because we know they're getting their pills every day. And then if they've gone into residential treatment, either for mental health or substance use disorder, oftentimes we aren't able to get the meds to them, but we will make every effort to do so. We've driven across the state to deliver the medication to folks if they call and request it. So SVR, this is the big one, right? We want to get people through the trial. We want to get them cured. So we're sitting at about 94.4%. We were at 100% before COVID. And as Dr. Volkoff mentioned, we've seen a lot of adverse effects of COVID on folks in terms of relapse, and that's what we have. All of these folks had relapsed at some point and began injecting again and began sharing. And we see that they're new infections, the majority are new infections, because we do genotyping. We can see it's a different genotype. So reinfection is also something we're looking at long-term. And so far, 3 of the 76 people, actually 2 of the 76 that we've seen at our 6-month visit were reinfected, and 1 came back at 4 months. He hadn't made it to a 6-month because he was tested as part of his buprenorphine treatment program and was found to be reinfected. So he came back to us early. All the folks that have either not achieved SVR who have been reinfected have attempted to start again. Not all of them have been successful, but they've all been motivated to restart. And we've been accommodating with that, and we've restarted everyone who has requested to restart. So finally, I'm going to go over the impacts of COVID and then some conclusions, and then I'm happy to answer some questions. So the university, since we are a research study, we're under the Vice President for Research. We were asked to cease as many of the activities as possible during at least those first 3 months. So March, April, May, and then some of June. So it was about 3 months. But understanding obviously that there were people in active medication trials, ours being one of them. So we were able to still deliver medication to people at their homes if they could come into the clinic, so we could do our RNA testing, our urine pregnancy screening. We had smaller clinical teams, and of course, following all sorts of COVID protocols and symptom screening for our participants. So recruitment was halted for those 3 months, and as well as from Thanksgiving through New Year's, there was the rates were very high in Perry County. We were having a hard time getting people to come in, and it just made sense to go back to the protocol that we had established when we couldn't recruit. So we were having small clinical teams delivering or doing in-person visits when necessary, but really trying to limit. We limited all recruitment, didn't do any recruitment, but just were able to provide the care that they needed for the folks who were already enrolled. All of our community screening activities have been canceled. So we had 5 events on the books, and we weren't able to do any of them. That's going to end up being one of our major recruitment tools. So once those get back going again, I think we'll see an uptick in recruitment. Every time we've come back from a phase where we weren't able to do recruitment, it's been really slow getting back up and running. So it would take about 6 weeks for the folks to really start to get going, even those who we were trying to reschedule for when they were, when we had to cancel their appointment during the pandemic. So I think it's like this for everybody. I don't think this is certainly unique at all. We have had several reinfections, again, due to relapse during the COVID, and then 2 overdoses that were fairly recent as well. So thus far, in the 220 folks we've enrolled to date, I think we've done a pretty good job in a population that can be challenging in recruiting, treating, and curing these rural residents. Excellent SVR rates, thus far low reinfection rates. We hope to keep it that way. We've had 21 restarts after those lost to follow-up. We'll have people just show up out of nowhere and say, hey, I'd like to start again, even though we've considered them lost to follow-up. Recruitment has slowed a little bit, so we've really tried to get some of those activities, those community-based activities going again, and regular recruitment days at the syringe program. And one thing that's, I think, has been fantastic. So additional providers in the area have actually started to treat HCV as the Medicaid restrictions have been either removed altogether or significantly lessened. And that's good. If we circle back to the original goal of Key Treat, which is to eliminate hepatitis from the community, the more people that are treating hepatitis in the community, the more likely we are to meet that goal. I think what Key Treat has done is demonstrated that everyone can and should be treated. And I think that the local providers have been encouraged by what they've seen us do and have begun to engage that population when previously they would not. So I need to acknowledge certainly NIH and NIDA for really spearheading this. Dr. Ward, when he was at CDC, was also fantastic. And really this collaboration between NIDA and NCI and Doug Lowy, who really took an interest when he visited and when Dr. Volkov visited, and they went back and talked about it and asked us to put this together. Gilead's been a fantastic partner. Really, they just want to know what's going on. They send us drug when we need it, and they like to get some updates because I think they're really interested in how this is going. And our team, I mentioned before we came on as a big group, have just absolutely responded in a fantastic way to these circumstances in the last month, and have really put those participants first and made sure they got what they needed, even though they weren't necessarily in a good place. So I couldn't be more pleased with the way that the study is going, especially given the past 12 months, and hope that we can continue to do some good in some of the rural areas that have been adversely impacted by the opioid epidemic. Thank you.
Thank you very much, Dr. Havens, for leading us off today with a really wonderful update about your elimination trial in rural Kentucky. While Dr. Irvin is getting her slides up, there are quite a few questions in the chat for you, Dr. Havens. I'll just relay a couple of them. But one of them that's very interesting is, can you explain how you identify the individuals that you attempted to reach by phone? So how'd you get all those phone contacts? Do they call you, or do you call them?
Well, it's a combination of both. So we did our PR department at the University of Kentucky is fantastic. So we did a, kind of a kickoff blitz, if you will, and that was picked up by the local media. And it was on it was WYMT Facebook page. Facebook is huge in Eastern Kentucky. So the Facebook page, they put the story on that. We got a lot of hits from that. And of course, small communities. So once a few people enrolled and said, hey, they're okay, word spread through the network. So we knew that that would likely happen. But we also, the study that you mentioned, that we're also conducting, we've been doing since 2008, that study provided the data that was the impetus for Key Treat. So we knew there were a lot of hepatitis C positive folks in that study. So when they signed the consent form, they agreed to be contacted for future studies. So we also already had kind of a built-in recruitment group, if you will, and we've been able to treat quite a few of the folks from that study as well.
Well, there are a lot of other questions, and I'm reluctant to not ask them, but I want to make sure we give our next speakers plenty of time. So thank you, Dr. Havens. And now we'll turn it over to Dr. Irvin. Dr. Risha Irvin is assistant professor at Johns Hopkins School of Medicine in the Division of Infectious Diseases, where she focuses her clinical care research and community engagement projects on improving the health of vulnerable populations impacted by HIV and/or Hep C. Dr. Irvin has served as an HIV Prevention Trials Network Scholar and a Presidential Leadership Scholar. Now, I was interested that of recent note, she's been working with the COVID-19 Prevention Trials Network on community engagement, both locally and nationally, and serves on the COVID-19 Vaccine Health Equity Group at Johns Hopkins. And while that isn't a topic for today, I think it speaks to the broad range of interests and expertise that Dr. Irvin brings to this issue of Hep C elimination.
Thank you so much for having me. As stated, my name is Risha Irvin, and I've had the pleasure to work with the Louisiana team since 2018 on their Louisiana Hepatitis C elimination plan. And we decided to embark on a research collaboration together so that we could rigorously document their work. So my title for today is HCV in Louisiana Corrections, a model for national elimination. Here are my disclosures. So what we know is that the majority of persons with untreated HCV infection in the US are associated with the correctional medical system. We also know that HCV infection is a significant cause of morbidity and mortality among people who inject drugs and people living with HIV, populations that are disproportionately represented within the correctional system. For example, it is estimated that 89% of people who inject drugs have been incarcerated at some point in their lives. We also know that HCV is curable with short duration all oral regimens, yet the care continuum remains broken many times, and particularly in correctional facilities across the US. Currently, incarcerated HCV infected persons comprise about half of all untreated persons. So we have a setting in which we know people have the hepatitis C virus. They have not been treated, yet there hasn't been large-scale scale-up of HCV testing and treatment in the correctional system. To achieve elimination goals, we will have to broadly spread HCV testing and treatment within corrections. So as mentioned, there are HCV elimination gaps in the US correctional system. And this map really signifies that. It shows US state prisoners receiving any treatment as a proportion of inmates with known HCV infection in January of 2015. If you look across the map, what you essentially see that treatment ranged from no treatment up to about 6% of individuals being treated within correctional facilities in the United States. I think this is problematic for many reasons, but if we think about health equity, obviously people should have access to curative therapies, but also as we think to our elimination goals, it's very important that we think about micro-elimination in populations where we need to roll out hepatitis C testing and treatment. So Louisiana said, we see this problem, what can we do about it? We have a cure, so this is fixable, we can do something, but the neediest people can't afford the treatment, particularly as you think about when DAAs first rolled out. And Louisiana wanted to change that. We've also seen some other states across the country also come up with models to achieve the same. So Louisiana developed a plan, their hepatitis C elimination plan, which had 7 key elements, which they launched in the summer of 2019. Again, in those kind of pre-COVID days. So first, they want to establish a modified hepatitis C medication subscription model within both Medicaid and corrections. And I'll talk about the implications of that later. But this is really to remove that financial burden that's been such a big issue for states. Next, they wanted to educate the public on the availability of cure and mobilize priority populations for screening. We all know it's important for people to know that they have hepatitis C infection. Then they wanted to expand hepatitis C screening and expedited linkage to cure. In the correctional system, they set up a system where they would essentially go around to the 8 state correctional facilities and offer hepatitis C testing to everyone. Right now, they're at number 6 out of those 8 state correctional facilities. They also implemented new hepatitis C testing on entry and exit from the correctional system. They also wanted to strengthen HCV surveillance to link persons previously diagnosed to treatment. They had a waiting list of people within the correctional system who had been waiting on hepatitis C treatment due to fibrosis restrictions and kind of funding issues. And so those people were prioritized for treatment. They also wanted to expand provider capacity. This was done in both Medicaid by trying to train more clinicians to treat hepatitis C and coming up with a standard algorithm, and also adopting that within corrections as well, and using telemedicine as a vehicle as well. Finally, they wanted to, in addition, they wanted to implement harm reduction and complementary treatment strategies. And then finally, to extend these elimination efforts to all populations in the state, because initially these have been focused within Medicaid and corrections. So I did just want to take a minute to look at their model, the funding piece, because that's such a huge barrier for many states across the country, that they use this treatment as a subscription model. So the elimination, hopefully, of the financial barrier. And so they pay the manufacturer for unlimited access to soft bill for a set annual cost over a set contractual period in Medicaid and corrections. In Medicaid, they use their annual expenditure cap. So essentially, once you get over that, regardless of volume, you're actually spending $0. And in corrections, they've used a system where they use the 340B drug pricing program to help remove this financial barrier. So now I wanted to turn and transition to our research project. So we know why the goal in Louisiana is clearly to eliminate hepatitis C for the public good. We reason that their example could be an example for the nation by removing this financial barrier and by also implementing a kind of comprehensive program, both within corrections and outside of corrections in the Medicaid system. And so we set out to look at these aims and try to look at what the impact on hepatitis C would be. So our aims were as follows. Aim 1, to characterize the dynamics of HCV infection in the correctional system among HIV, HCV co-infected and HCV mono-infected incarcerated persons. Aim 2, to assess this treatment trajectory, the impact as the trajectory of decline in HCV viremia among HCV antibody positive incarcerated persons, and whether this trajectory differs between those with and without HIV. And then aim 3, to disentangle the impact of the correctional HCV treatment program on HCV viremic decline, and assess the impact of scale-up of the correctional treatment programs on HCV incidence and mortality in Louisiana and elsewhere. So this is really our modeling aim so that we can think about impact across the country. So I'm going to go back through now and talk a little bit about the aims. So aim 1 was really to characterize these dynamics of HCV infection and corrections. We were awarded this grant from NIDA in the fall of 2020. So a lot of this work in terms of the research portion is just ramping up. But what we realized is there's not a lot of data as of yet in terms of what was going on in corrections. So first we want to establish this HCV antibody prevalence in incarcerated persons in both the prison and jail system. As mentioned, there are 8 state correctional facilities. So the prison system, there's over 100 parish jails. And there are differences in terms of kind of the populations housed. So the prison systems, the average length of stay from earlier data is about 11 years. For the jail system, it's about 2 to 3 years. So we may see different dynamics in play when we think about hepatitis C. So the Louisiana Department of Health and the Louisiana Department of Public Safety and Corrections implemented an HCV testing program across these 8 state correctional facilities. Again, as we think about COVID-19, because this is when things were really ramping up, COVID-19 hit. And so this testing was initially anticipated to be done in 2020. That has moved to 2021 right now as things are ramping back up. While we'll look at all of the 8 state correctional facilities, 3 jails have been chosen as a representative sample. We'll also look at an estimation of HCV antibody prevalence in the community because we know that there's an interaction between kind of the community and the prison jail system and that people can move back and forth, and we want to look at that interplay. Finally, we'll characterize the dynamics of incarceration and interdomain transition. And by that, I mean, we'll look at factors such as incarceration length of stay, prison jail facility movement and release, reincarceration, injection drug use, the availability of opioid substitution therapy, and look at any impact on HCV transmission, kind of reinfection, acquisition as well in the system. So I just wanted to show this as our conceptual model. So essentially we're looking at different domains, the prison system in blue, the jail system in green, and the community in orange. And what we know is that people can move back and forth between these different domains. They can go from prison to jail, jail to the community, and move throughout. From 2020 to 2024, essentially we'll be looking at the Louisiana Elimination program and trying to measure the impact. And so the black dotted hashed part is the viremia level. So we would expect that to go down. But what we want to do in each one of these domains, but what we want to do is kind of tease out the impact between the community and incarcerated persons in the prison and jail system, and also look at where you kind of get the biggest bang for your buck. What programs or what elements of their system really led to any declines in viremia? So then aim 2 moves on to look at that viremia. So to assess treatment impact as a trajectory of decline in HCV viremia. As we know, once someone is infected with hepatitis C, that they either spontaneously clear or they remain viremic without treatment. And we also know that reinfection is possible. So what we want to do is look at this viremia proportion by looking at chronic infection plus the reinfection and taking out kind of spontaneous clearance and treatment when people are cured over our HCV antibodies and document kind of that decline and look how things proceed. So we'll look again in both prisons and jails, and we'll get data from the overall HCV program data. So the RNA status of each person enrolled in the treatment program post-treatment, all reported HCV antibody RNA data for the ongoing program, because remember, they're going around initially testing everyone. People will continue to come in to the system as well and to also leave the system. And then we'll also look at transition to different facilities and communities as well and see if that has any impact on HCV status. In terms of our research protocol, though, we'll be using samples across the 8 state correctional facilities and in those 3 sample jails to look at reinfection, transmission, any missed cases, so including people who decline testing or treatment, and clearance. We'll also be looking at HIV and getting a fibrosis assessment using the FIB-4, and also asking individuals to complete a survey so that we can assess for risk factors for HCV infection and transmission, knowledge of HCV infection, any prior treatment within corrections or in the community as well, and whether or not they're enrolled in any harm reduction. Because again, remember, we're looking to tease out kind of where you get the biggest bang for your buck. We'll look at community viremia by bringing in data from the Louisiana Medicaid system on HCV prescriptions and treatment, their HCV antibody and RNA data, which go to the Louisiana Department of Health. They also get all negative results now. That was something that they changed in terms of their program across the state. And then we'll also get a community sample amongst people who inject drugs using a dry blood spot. And they'll also complete a survey similar to what we've done in corrections so that we can have a sense of what's going on in terms of these dynamics in the community as well. So then we'll take the data that we have from AIM-1 and AIM-2, and AIM-3 really moves to model this data and look at the long-term implications and what might happen across the country if other states would take this model up. So we're essentially looking to answer kind of three questions. Are the observed reductions in HCV viremia among HCV antibody positive persons in corrections consistent with what we would have expected with intervention scale-up? What is the likely interim impact of the corrections HCV treatment program on HCV incidence and HCV-related mortality overall? And are the Louisiana treatment programs in the community and corrections on track to achieve the targets in terms of when we think about HCV elimination and mortality goals? And if not, what level of farther scale up is required? What else would need to be done essentially? So as we think about the modeling aim, we essentially think about this incarceration component, the population component, and then the HCV natural history. So in incarceration, again, people can be never incarcerated, move between the prison and jail system, and can be released into the population. A large portion of the people that we're looking at are people who inject drugs. And so again, we'll be looking at that dynamic. And then finally, the overlay, this is on top of the natural history of HCV, because we'll be looking at kind of mortality endpoint goals. So I just wanted to walk through some of our preliminary data that's come out of the HCV testing and treatment program. So this just shows some of the mobile screening kind of tests. These are the 8 state correctional facilities in Louisiana. So they've essentially gone around to these facilities. As mentioned, they've gone to 6 out of 8. 2 are still remaining right now to get around to, and offering hepatitis C testing to everyone. Before kind of COVID, the refusal rate was around 5% for the initial 2 facilities that they had done. Things slowed down during COVID, but the other impact was that there were more refusals during that period as well, and probably because people just had different competing priorities in the midst of the pandemic as well. So some of these facilities will actually be visited again. There are about 14,000 people in state correctional facilities. So this data goes through January. So we'll be continuing to ramp up to get to everyone. So this looks at the HCV antibody positive and kind of the RNA positive status. So you'll see for antibodies, it ranges from 6.4 to about 22%. And for RNA, for 3.1 to 14.4. So again, I think this just shows you that we have a lot of people within corrections. These are the state correctional facilities with hepatitis C, and we have to get treatment into these facilities. Again, I think it's just so important for us to acknowledge what the impact of COVID-19 has been. This chart from the Louisiana team shows kind of how treatment ramped up in the summer of 2019 when they kicked off kind of their HCV elimination program. They had press around it. They had done their medication deal, starting to train providers. And so treatment really skyrocketed and was going along pretty good. COVID-19 hit, obviously, and we saw this steep decline that has been rebounding now. And I'm sure we'll continue to keep coming back as well. This is the HCV treatment care cascade in the state correctional facilities. So if you look at the top graph in green, this is all kind of the DOC cohorts in 2020. In this graph, people are at different stages. So some people haven't reached kind of the portion where they would have completed treatment yet, or to be able to check for cure, but we wanted to show kind of where everyone, if we looked at everyone. So you'll see some drop-offs there. If you look at the second graph in yellow, these are just the kind of cohort of treatment between January to August. So it includes 500 persons. These people had completed treatment and were 12 weeks post-treatment, so you could check for cure. So you see less of a drop off here. In terms of the issues that they have noted in their care cascade, that there have been some medication issues, medical issues where people had something else come up in the middle of treatment. There have been some individuals who have refused treatment after testing positive. And then there are people who were released before treatment was issued. I will say they've established a program now where upon exit, people are linked to a provider in the community so that they can get treatment, and it's made sure that people have gotten signed up for Medicaid as well, if needed. And they have a system now to feed that data back into their system. So I think we'll continue to see these numbers kind of rise as that data comes into the system. So I think in summary, you know, Louisiana can really be a model for HCV elimination in incarcerated persons. And I just think it's just really something that we really have to do if we want to reach HCV elimination goals. And I think a part of this project is really exciting because I think the modeling will really allow other states to identify factors most responsible for that decline in HCV viremia. So I'm really excited to see what this shows. I have to give a big thank you to everyone on the Louisiana team. This is kind of all the people who have taken on leadership roles, but this has really been a whole statewide effort from people really mobilizing to prioritize hepatitis C testing and treatment in both Medicaid and corrections. And they've just really been kind of rock stars. And I'm just so proud to be able to work with them and collaborate with them. And then finally, just want to thank all of my kind of research collaborators, our Johns Hopkins team, and want to acknowledge my mentor, who is really kind of the reason I'm in academic medicine, Dr. Thomas, who's also available with me for the panel kind of questions as well. Dr. Natasha Martin and Javier Cepeda, who are working on helping us with the kind of modeling components, and Dr. Rich as well, one of our consultants who has worked a long time on research in incarcerated persons, and it's helping us on this project as well. So thank you all so much.
Thanks, Dr. Irvin. That was fascinating. And it's interesting, you described it as sort of micro-population work, but it's not a micro-population. This is a large, diverse, and complex area, and I'm so glad you all are tackling this. There was one question while Dr. Allen is getting his materials ready that I wanted to relate to you about access to syringe services programs as part of the long-term prevention approaches once they're re-entered into the community, whether that was part of your program or what thoughts you all had given to that.
Sure, yeah, so we've talked a lot about that. So the Louisiana team, you know, again, they're working a lot in the community and in correction. So that is a part of the overall program. In terms of this kind of research grant, it's not something as much that we're kind of doing in the setting of corrections, but in the broader Louisiana program, yes.
Got it. Thanks very much. Well, I know we have more to ask you, but we'll keep moving along. Next will be Dr. Todd Allen, who is a professor of medicine at Harvard Medical School and the Ragon Institute of Mass General Hospital, MIT, and Harvard. Dr. Allen's laboratory is particularly focused on understanding the immunological and virological factors influencing transmission and immune control of highly variable pathogens like HIV and HCV, and exploiting these findings to generate effective vaccine immunogens. Currently, his lab is applying next-gen sequencing technologies to characterize the boundaries by which HIV and HCV transmission and evolution is restricted and influenced by host antiviral responses. And I am quite confident that we'll all be excited by some of the results of the ghost laboratory work that you've been conducting. With that, I'll turn it over to Dr. Allen.
Great, thank you, Wilson. And thank you for the opportunity to talk to the group today about some of our work. You know, the title here is really the title of the RFA that we all sort of ended up applying for, but the focus here is really around working within opioid injection drug epidemics and trying to understand and identify appropriate ways to prevent and treat. And, you know, we tried to come up with a good acronym for this and we really couldn't. So, you know, we really just refer to ourselves as the Rural Opioid Initiative. But importantly, it really does represent a collaboration across NIDA, the CDC, SAMHSA, and the Appalachian Regional Commission. And I think it's really been fundamental and important to see how all these different sort of clinical or on the ground sites are dealing with the opioid epidemic in their own way, and some of the unique hurdles they have and some of the shared responses they've been able to generate to address it. This map just shows sort of the 8 different sort of clinical or on the ground sites in Oregon, Wisconsin, Ohio, New England, West Virginia, North Carolina, Kentucky, and Illinois. And each of those groups are sort of focused on enrolling individuals, testing for Hep C, respondent-driven sampling to collect information and to understand exactly what their local epidemics and transmission networks sort of look like. Our group here at the Ragon Institute overlays the GHOST Lab, which is a sort of a tool that was developed by the CDC that we've helped to implement here across these different sites. And then we have a data coordination center up at University of Washington. So, you know, the focus of the 8 sites is really sort of a biphasic, multi-method research projects that inform community response and integrated approaches to prevent HIV and HCV infections among PWIDs in rural communities. And the first 2 years was really sort of a local community assessment of what their local epidemics look like. And then the next 3 years was really to propose and implement evidence-based practices to address opioid use and related comorbidities. And my lab here at the Ragon has really been focused on sequencing of the virus using next generation sequencing approaches and phylogenetic approaches to identify linkage between the different viral sequences to see if we can overlay and expand upon what the UH3 sites are doing, and to, you know, fundamentally try to understand, if we look at sort of a large cohort of people who have been HCV positive and look at the sequence and try to relate and understand where exactly certain sequences are showing up that are similar across individuals, and identify and ask whether or not molecular epidemiology can identify subjects infected with the same strain of HCV to potentially uncover patterns and networks of transmission that might help to inform local prevention, treatment, and control. And so I'm really going to focus on the molecular epidemiology aspect of all of this. And for those that are really, you know, more interested in this, I would point people to this, I think, wonderful review. And this is on HIV transmission and phylogenetic analysis. But I think a lot of the same lessons and applications apply. You know, I think we've been doing this for a number of years in HIV, and I think that's been very helpful for identifying exactly where transmissions are coming from. And as they point out in their review, in high-income countries, a lot of that transmission is between recently infected MSM, and really with a focus on the acute phase of infection when viral loads are very high and people are more apt to transmit. But it's taught us a lot about, you know, in the rural setting, especially in South Africa, where transmission between different communities tends to occur, and that indicates a lot of travel-associated transmissions that need to be contended with, as opposed to sort of a local community approach. And it's also certainly raised issues and identified the age discrepancies between men and women, where oftentimes older men are linked to transmission to younger women, and identifies, again, sort of different points where we can sort of intervene in more appropriate ways and identify exactly how transmissions are occurring in sort of local settings. They also talk about sort of the predictive value. I think if you can understand exactly where transmissions are taking place, there's opportunities to prevent infections, and you can sort of predict that, and that includes pre-exposure prophylaxis. And they also sort of point to one study, this is out of BC, Canada, in terms of a drug-resistant strain of HIV, and the opportunities to apply this type of approach to identify either larger networks of individuals that may be growing in terms of the spread of a particular strain of the virus, or particular drug-resistant variants that might want to be headed off earlier. But they also touch on sort of the fact that this type of approach does require dense sampling of patients, and, you know, a small time gap between the point at which the sample was collected and the sequence data generated, and the need to really act on that sort of in a timely manner. And of course, the cost effectiveness of the approach needs to be considered in light of other intervention approaches. Now, with respect to the work that we've been doing with Hep C, the basic approach is that clinical samples are collected. In this case, they're collected locally. They're actually processed locally. They're then sent to our lab here in Boston, where we amplify a small region of envelope and then deep sequence that particular region. And you know, the distinction here between sort of conventional Sanger sequencing and deep sequencing is sort of analogous, I guess, to Sanger being understanding what a book is about, and maybe a book about trains. But if you open up that book and read through it, you understand that there are actually thousands of different types of trains. And so while that's a book that's different about something than boats, we can get a lot more information, a lot more accuracy and stringency by applying the deep sequence data, where we can look at thousands of different strains of the virus in each sample that we look at. And so in this case, because of that sort of stringency, we can actually get away with sequencing a very small region, in this case, the hypervariable region of Hep C, which is the most variable region, but it's a short one and therefore a very small PCR product that's much more amenable in the lab, both to amplification and to sequencing. And so sort of the best known example of this, I think, is in the case of the Scott County HIV outbreak, in terms of the application of HCV phylogenetics to understand that outbreak, which really grew from a small number of cases in January 2015 up to almost 200 cases by the end of the year. 92% of those cases were Hep C positive, and that indicated or brought to light the fact that there was really this underlying HCV epidemic that was, in essence, driving the HIV infections in the area. And also that there was really sort of a large cluster of about almost 200 individuals that accounted for about 70% of all the infections. And so the thought being that, well, if we'd known this at the time, could we have headed this off a little faster, not only knowing that there was an increase in HIV infections, but potentially exactly how and where that was spreading. Now, this is a very unique case because this is a very concentrated outbreak, a very fast-moving epidemic, and raises the question about whether this can be applied in sort of a more generic fashion, and in particular to sort of a rural setting. And so the approach we use is really predicated on a program that the CDC's hepatitis group had developed, which is called GHOST, which stands for Global Health Outbreak and Surveillance Technology. And it's really taking that sequence data, or that next-gen sequencing data, and applying a phylogenetic approach to determine which sequences are really and most accurately linked to one another versus those that would represent truly independent infections. And so our role here as the GHOST lab is to generate the sequence data and work with the CDC directly. So linking those UH3 clinical sites where they're enrolling patients and looking at RDS data and linking that to sort of the CDC's network and trying to apply sort of this molecular epidemiology. So our progress to date, again, across these 8 different sites, they've been able to collect almost 1,400 HCV antibody positive samples. And this is really an enormous amount of work. Again, these are sites that are already undertaking their normal research projects. And then we're also collecting and processing on site, and in some cases in a very rural setting, samples in real time. And so the blood samples needed to be collected through a local phlebotomist. They needed to be processed on site in terms of centrifugation and frozen and then shipped to us eventually. And so I think we uncovered a large number of sort of smaller steps, but nonetheless critical ones to sort of the type of enrollment or rollout that would be required to do this more routinely. We are also in the case of Wisconsin, fortunate to be able to sort of pull back and look at some retrospective samples that were from the same area as their prospective samples that were being collected. And so of those 1,400 HCV antibody positive samples, we've been able to complete PCR amplification of the virus from just short of 1,000. PCR failed rate was about 13%, which is actually largely driven by antibody positive RNA negative samples, very similar to what Risha was noting. And so again, even there on the ground, our ability to distinguish between the antibody positive and a active RNA positive sample in real time is still a barrier. But we were able to amplify, well over 90% of those, and they were able to pass the metrics in terms of robust sequence data that was needed for the downstream GHOST portal. And so what does that data look like? So we can look at the case of Oregon. There were 42 individuals sequenced, 16 of those clustered, so 38% clustering. Those clusters ended up being largely dyads or pairs of individuals, which is actually pretty impressive in the sense of a small collection of 42 individuals. The colors denote the genotype of the virus. That was the infecting genotype. But it also raises across each of these sites, as we look at Ohio, 10%, North Carolina, 35%, that there are differences in the rate of clustering, but that's also potentially largely influenced by the rate at which the patients are enrolled. You can imagine in a case where you may have one seed individual who goes out to invite other individuals into the trial, and they might bring in 10 people, or you might have 10 seeds which go out and bring in one individual each. And so the rate at which the patients are brought into the study can have a big impact on sort of the molecular epidemiology as well. And so that's something that we're trying to understand across these different sites that have different enrollment criteria and approaches, to what degree that's an influence on this. We can look at Kentucky and New England, where we see much larger numbers of samples sequenced to date and end up with very different levels of clustering. Again, 16% in Kentucky, 42% in New England. And again, the enrollment types that we think are probably one of the larger drivers, rather than there being sort of distinct microepidemics, if you will, within these two different areas. We can look at something like Wisconsin, where we'd be able to combine both the prospective and the retrospective data to look at upwards of 400 individuals. Here we can see that the rate of clustering is about 38%. So even though we've increased the number of samples dramatically, the rate of clustering is about on par for what we saw with New England. But we do start to see these larger clusters of 14 individuals, and we can sort of look back in time a little bit. And I think that's one of the powers of the approach, is that back in 2016, this actually represented just 2 individuals that were linked. In 2016, 2017, as we added more data, that cluster grew to 8, and then by end of 2018, we were up to 14 individuals. And I think this is sort of one of the potentials of this approach, is to identify these clusters as they grow and determine whether or not there's an opportunity to intervene with one or more individuals within those clusters to try to sort of short circuit that transmission chain. And maybe those are settings where a small amount of effort can lead to a larger amount of reduction in transmissions. We can also sort of overlay that with the respondent-driven sampling in terms of how individuals are perceived to be linked at enrollment. Here we're just simply demonstrating that we can confirm that the RDS data in terms of linkage is supported by the viral sequence data, but we have a number of other examples where that data doesn't shore up, in terms of the fact that there are cases where individuals may be deemed to be potentially linked through RDS, but in fact are not confirmed through sequencing. And so, you know, to that end, we've been working with Kim Page and her group over a number of years on their UFO study. And this is a HCV You Find Out study of prospective observational study of HCV transmission and acquisition among young people who inject with drugs. And, you know, the key point of this study was to enroll those at risk for HCV, or those that were seronegative viremic upon enrollment, and then up to 3 HCV RNA positive injecting partners. And, you know, Kim's group then conducted a survey, a baseline behavioral questionnaire. And our role here was to sort of overlay the viral sequencing data to understand, you know, in which cases was there direct transmission, or at least presumed direct transmission, and allow that to sort of further enhance the value of the RDS data in terms of understanding when there was an actual transmission event, and then what the RDS data would tell you there, as opposed to sort of assuming that all of the RDS data and individuals that were deemed to be sort of linked upon enrollment were actually cases where the virus was actually transmitting. And importantly, the partnerships were relatively loosely defined in this study, in terms of the fact that they were asking for individuals that were injecting at least 5 times in the same physical space, that they were RNA serodiscordant upon enrollment, but eligibility didn't require actual sharing. And so if we look at that cohort here, this was 101 injecting partnerships, which constituted about 25 clusters. Majority of these were dyadic in terms of these partner pairs or just a pair of individuals, but there were a number of other complex networks of multiple individuals. And notably about 33% were in a sexual relationship. And so Kim's group undertook sort of a study to understand exactly what might be associated with potential risk for acute HCV infection, and identified 25 new HCV infections. And then if we take a look at the viral sequence data, we could generate sequence data from the core to NS2 region, a slightly larger region than I talked about earlier. And we generate sequence data from a number of these individuals and then could, based on phylogeny, understand exactly which sequences were related. In other words, there's enough of an identity or identical sequence in two individuals to deem them have been infected with the same strain. You know, and oftentimes we'll presume that to be a direct transmission, but it may well be that there's an individual or more in between those, but they are certainly infected with the same strain of the virus. And so we did that with one region of the virus with core to NS2. We could also do that with another region of NS5B. But in total, we identified that of those 25 new infections, 12 were phylogenetically linked to at least one partner, which also means that the other 13 were infections from outside of that originally identified partner pair. And then in terms of adjusting for factors that were associated with transmission, you know, the number of days that the partners injected, an odds ratio of 1.07, ancillary equipment sharing, odds ratio of 5, and the index partner being HCV seronegative, but in the viremic phase, indicating that they were likely acute infection, but had not seroconverted. But interesting, HCV viremia was not also found to be associated. And we would interpret that to mean that, in fact, individuals that are in the acute phase of infection are more apt to transmit, although the fact that the viral loads can fluctuate quite dramatically within the acute phase is probably why we're seeing viremia as a cofactor that fell out. Now we sort of taken that another step farther in terms of looking more closely at the sequence data. So in addition to confirming 12 of those self-described partnerships by sequencing, we also identified 3 new links between individuals within that cohort, including one that was identified only through a minor variant that we would not have picked up with Sanger sequencing. But interesting, the partnerships were more likely to be genetically linked if they shared only one connecting edge, meaning that we sort of go back and look at the larger network, situations where there's really a case where the index patient only enrolls or self-enrolls one additional subject were ones where we actually ended up seeing that the virus was more likely to be linked in the individuals infected with the same strain, as opposed to sort of the larger networks where that the infection was often coming from outside of the pre-described partnerships. And we also saw a strong signal for linked partnerships to be reporting and engaging in a sexual relationship. Again, sort of driving towards the issue of the closeness of the relationship of the individuals. And I'll just wrap up with sort of this last part around dried blood spot, because I think it's something that we're moving towards in terms of feasibility. You know, sample collection, as I mentioned, and local processing was a substantial burden. And if we take a look at sort of samples from about 10 patients here, and we're looking at the amount of diversity within any given sample, repeated from either the plasma sample or different dried blood spot approaches, we get very good concordance in terms of the ability of dried blood spot approach able to accurately collect the type of sequence data that we need. And so I think this approach is very feasible to dried blood spot, and certainly would pair with other approaches that dried blood spot could have in terms of the surveillance of Hep C. And this just goes to show a very strong concordance between those different approaches. So, and just to wrap up, you know, the transmission network analysis is feasible across rural communities, but it is burdened by sample collection, sample processing, and shipping. And I think it's a place where the dried blood spot approach could really make great inroads. And there were significant delays in data turnaround, largely due to financial costs of the shipments. And so we tended to batch those, which limited sort of real-time implementation and follow-up. But I think there's a great proof of concept for scaling it up. We were able to identify a number of different clusters within the majority of the cohorts, and the clustering range significantly across cohorts, again, suggesting that there are other factors that may be driving the level of clustering that we see at each of these sites. And cluster detection is dependent upon sampling density, and I think it's a case of something that needs to be done at scale. But I think at that point, the cost of the approach can come down quite dramatically. And I'll end there. I think really the kudos go to the unique UH3 sites. I think they're the ones who've been really doing the majority of the heavy lifting here on this project, but also from my lab, Karen Power, Damien, and Jackie, and certainly the funding across NIDA, CDC, SAMHSA, and AR and the ARC. And I'll take any questions.
Thank you very much, Dr. Allen. That was a wonderful presentation to wrap up our full presentations today. One of our discussants had a question for you in the chat that I'll relay while we get ready to open it up for our three brief discussants, and then maybe a couple of questions from the rest of the participants. Dr. Page asked, are there any sites in the project using the cluster information to treat, a dyad or a cluster, not bringing one person in for treatment, but bringing a whole group in simultaneously?
Yeah, and not at this point, not that I'm aware of. I know that Wisconsin has taken great efforts to try to bring this type of technology in-house within the Wisconsin State Lab, and I think that will allow them to work much more real time. And I think that's an important aspect of this, is that state labs can and are adopting this type of approach in conjunction with the CDC that's very willing to get labs up and trained locally.
Well, thank you. I know we have multiple questions for you, just like we have for our other speakers, but let me quickly introduce our three panelists who will provide some comments to kick off discussion. Dr. Kim Page is Professor Epidemiologist of Biostatistics and Preventive Medicine at the University of New Mexico. Dr. Alan Litwin is Professor at Clemson University School of Health Research and Vice Chair for Academics and Research, Prisma Health Upstate. And finally, Reverend Michelle Mathis is Executive Director of the Olive Branch Ministry. And in particular, she oversees the North Carolina Tri-County Overdose Response Teams and Points of Hope, a Justice Center Education and Syringe Services program that includes low barrier, low threshold Suboxone and Hep C treatment. And I wanted to emphasize those as being essential services to a stigmatized, highly vulnerable population. But first, I think we'll ask for a brief comment from Dr. Page, Dr. Litwin, and then Reverend Mathis. So Kim, you're up first.
Some of my comments were already addressed, in particular, hearing from Todd just now. These were all really great presentations, and it's remarkable to see the progress here. I would really like to hear from Risha. What are some of the main metrics that you're using, sources of data that you're using to really look at the population impact in the different settings, even if you just can address one? Like, what's the main thing? Is it viral RNA, et cetera? And how can that be translated to actually be used in communities more readily?
Sure. So I think, we're really focused on this trajectory of decline in the HCV viremia, which I think is really important, and to see how quickly that goes down, because we know we have this program, but how rapidly will we see that? But I think the important piece is the third aim, kind of the modeling, to really try to tease out what's leading to that decline in viremia, because we know we expected, we're implementing a testing and treatment program, but what's causing that? And so we're going to be looking at kind of, our survey data to look at, whether or not people are enrolling in opioid substitution therapy, looking at transmission in prison and kind of what that looks like, looking at whether length of stay within the prison system or within the jail and cycling in and out into the community leads to more kind of reinfection or kind of coming back in the system. And so trying to look at all of those dynamics, because I think the big piece we want to be able to do at the end of this is tell other states how you can implement this program and what makes the most sense to do, because everyone may not have the same financial piece. So what pieces can you pull out to get the most treatment impact to lead to HCV elimination? So I think kind of that's what we're really trying to tease out. Again, we're just, kind of launching this. So really excited about the work. But at the end of that, that's what we hope to be able to do.
That makes sense because we often lose a lot of people and don't know their SVR. As we saw in Kentucky, and we've seen it in our other studies. So maybe knowing upstream who's gonna, how we can support that success is the most critical thing. Thank you.
Dr. Litwin, your chance for rapid fire questions.
Great. I have some comments to just great presentations all the way around. Dr. Haven, really exciting, the Key Treat study. I do think having that nurse-led model or other pharmacy-led, nurse practitioner-led, PA-led models could be more cost-effective. Had a question really for around a couple things. The loss to follow-up, because we found in our HERO study that treatment completion was a great marker for SVR, and with so many people achieving, when they complete treatment, 95% or more achieve SVR, perhaps that could be an outcome in itself and we can move away from SVR. But how have you handled the loss to follow-up? I noticed that quite a few, just like with our study, were lost to follow-up. And was that 94% an intent to treat, or was that just for the people that had the per protocol analysis? And also kind of the social determinants of health of kind of the housing and transportation needs, how those were being addressed.
Absolutely. So that's not intent to treat. That was amongst the people who did complete treatment, and you're absolutely right. The people who did complete treatment do really well. So that's why I think we're at the point where we likely have statistical power to actually be able to look at some of the factors involved in looking at those 50 people that are lost to follow-up, and what is there something unique about that population that we can hone in on in terms of an intervention, or at least to adapt our protocol so that we can address some of those issues. I think one of the main ones I sort of touched on, but it's hard to talk a lot about it, but it goes into your second point about the social determinants of health, was homelessness. So homelessness is not really something that is addressed a lot in the rural communities, because it's thought that a lot of people have family there, so they always have a couch potentially to surf, but in Hazard, we had this unique situation where it happens to be where one of the main state facilities for mental health treatment are. And oftentimes they're bringing in people from other states to come to this facility. And then once they're released, they're released into Hazard. And if they don't have a place to go back to, there's really not a lot of linkage to care once they're released. So we had this group of people who were at this homeless shelter who oftentimes didn't have that network of people because they weren't from the community. So that population, and if they did end up linking back with someone from their hometown, then they would disappear. So I wanted to focus in on that. I wanted to go after those people who are homeless because I think that that's a really important population. But at the same time, they were the main driver of our loss to follow-up, unfortunately. So
that's fascinating. Yeah, and 30 seconds I have left here. We found the same thing in HERO, that was the biggest predictor of not initiating, of not completing, and not achieving SVR. So really, and I love that you started the medications at the first visit. That's incredible. That's what they do in Australia, because at every moment you're going to lose contact, and if you make them come back.
Absolutely.
MinMod study, Dr. Solomon's study from the SLD, really intriguing, for all of us to kind of consider, is it better just to hand people 84 pills or 2 months worth of medications, because sometimes in our best intentions to give more follow-up to patients, making them jump through some hoops to come back for medicines might actually be the reason why they are lost to follow-up. And I just want to say great work, Dr. Irvin and Alan as well. One thing with the prisons is, lack of syringe service programs that we've heard from Dr. Treloar, and not having MAT access, that somehow it could be, it's interesting, the psychological effects. People are kind of held responsible for not being reinfected, but there's almost this inevitable sense that you are going to be reinfected if you're in prison. And so, I think we're probably out of time, but I'd love to talk, offline about some of those issues. So thank you so much for this presentation.
Reverend Mathis, let's turn to you for a few comments and a question or two.
I am not a clinician. I'm a harm reductionist and a pastor, but I just would like to share briefly about our program and offer some encouraging words to something that Dr. Haven said. Valentine's Day of last year, we began a low barrier Hep C treatment program for participants of our syringe access program, and we are in rural North Carolina. We started the program about 6 weeks before the pandemic hit, and we started by hosting pizza parties and testing parties in people's homes or where they gathered. Our center operates, we have a holistic harm reduction center, and we operate with support from Gilead Sciences under the Hep Connect initiative. And we also partner with High Country Community Health, which is a local FQHC. They are the clinical supporter of our low barrier Hep C and Suboxone programs. Our labs are performed there with their indigent care funding, so our folks don't have to pay for that. And the medicine is accessed through drug assistance programs, so the medication for Hep C treatment is free to our syringe access participants. And we use almost solely Maverick in treating patients. Since February 14th of last year, we've engaged 56 individuals actively who are active injection users. And we were able to identify them either through positive rapid Hep C test or self-disclosure of Hep C infection. And this is, I want to encourage Dr. Haven. You mentioned questioning individuals who inject meth, and the majority of our folks that are participating in the program do inject meth. Of the 56, 33 have either finished treatment or are currently taking treatment or are waiting to start. And this speaks to really offering treatment in a setting of syringe access and the relationships that are developed there. It's important to note that through treatment and then post-treatment, our folks remain engaged in harm reduction services in the hope that reinfection does not occur. And although these numbers may be small, given some of the numbers that we've heard today, we believe that this program is really impactful and encourages folks to think outside the box when making partnerships, because we're in a non-clinical rural setting, literally in the woods, in people's homes, and in hotel rooms. And that's where we go. Our mission at Olive Branch is to extend hope and to extend life, and our low barrier Hep C program does both.
Well, Reverend Mathis, I think those comments really complement what we've heard from the others. While some of the numbers are higher, they are all addressing highly vulnerable populations, including many rural areas. So it's absolutely consistent. There is one more question in the chat I want to relay that Dr. Volkov asked: do we see differences in success with treatment between men and women? And I turn to Dr. Havens for your preliminary data about that, and maybe from some of your past data, Dr. Irvin, if you see that in your treatment completion rates.
That's definitely something we want to look at, because I mentioned briefly how about 50% of the women that call, 50% of the folks that call are women, but we're only getting about 45% who are enrolling. So I think there might be something there. And I think it goes to the extra caregiving responsibilities that women have and the inability to, commit to something else, put something else on their plate oftentimes. And so that certainly will be something we will be looking at. And I think we'll have adequate statistical power, given we're about, 45, 55, to be able to look to see if there are any differences in outcomes among men and women.
Dr. Irvin, any additional comments from your early or preliminary data?
Yeah, so the one thing, there's only one state correctional facility that houses women, and it was one of the earlier sites prior to COVID hitting. Treatment uptake was high, only about 5% declined. Initial kind of testing for hepatitis C and treatment uptake was very high. Around that same time, one of the male prisons was done as well, and it looked about the same. The issue is the other male prisons have happened in the setting of COVID. And so it's a little bit harder to know if it's just the impact of COVID and kind of different priorities in terms of what people are having in terms of uptake. So I think it's something we're going to have to keep looking at to look at kind of long-term what we see, if there's any difference between the kind of one female site and our other kind of 7 state correctional facilities. And then looking in we haven't moved into the jail system as of yet.
Yeah, and I was also curious in the network analysis, how do the women versus the male locate? To what extent that transmission that you're seeing for the phylogenetic analysis of the virus is I predict it's going to be much more likely to have males as transmitters, but is that always the case or not?
Yeah, I don't recall from the UFO study that fell out in any way. Oftentimes it's difficult to deem the direction of transmission if we don't have sort of a true negative sample beforehand. So I don't know, we've seen anything where there's a preferential male to female or female to male. I don't know if Kim's shaking her head no as well.
No, we didn't, but we did see preferential young to young rather than old to young, which a lot of people assume.
Well, clearly there's room for a lot more discussion, exchange of information, and all of these studies are at fairly early stages. So we look forward to hearing the results going down the road, and maybe we'll have another opportunity to convene this group. Dr. Ward, I'll turn it over to you for some wrap-up comments and see if there's anything else we want to do today before we wrap up.
Well, thank you. We had a really robust discussion. I wish we could continue it. It's really great information, and I know I had several on my mind. So please add a few more while we're still on the line for those of you that have some questions. Also, we'll do our best to get them together and get the answers up on that website that I showed you at the start of the program. It's also really great to hear from Michelle Mathis about how this work really can assist the type of work she's doing outside the study setting. And that's really what we're all about, is trying to propagate this information and translate it into practice. Someone mentioned it'd be great to continue this dialogue and get people sharing lessons learned. We're certainly part of that effort is in our coalition building the community of practice. And so we'll be working with NIH, CDC, and others to help out in that regard. Please be aware of our next webinar for the NIH series. That will be on May 13th, again at 3 o'clock, where we'll be looking at research into racial and ethnic disparities related to hepatitis and the social determinants of health that are contributing to those. So here's a preliminary outline of that program. And for those, again, of you who've registered for the series, you'll be getting more information about this as that agenda is finalized, and we'll be sending you a reminder. Please keep in touch. Again, send in some more comments and questions. If you have any other questions about the program, you can contact me at jward@taskforce.org. Have a good day, everyone.